Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are key words or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Charles Hawley, NAHDO's Director of Projects. Charles, the stage is yours.
Thank you, Claire. It's a pleasure to be here with all of you. And thank you for joining this session, Driving Data Quality, Overcoming Challenges and Best Practices for Reporting, which was organized by Mathieu, who will also be today's moderator. So let me go ahead and bring Jonathan on stage. Hi, Jonathan. You have the floor.
Thank you, Charles, and welcome everybody. Quick reminder to please use the chat function to enter questions. Hopefully everybody's used to that. My name is Jonathan Mathieu. I'm a senior consultant at Friedman Healthcare. I started my APCD journey in 2012 at the Center for Improving Value in Healthcare, or CIVIC, in the Colorado APCD, and I've been with Friedman Healthcare since 2019. Today's session, Driving Data Quality, Overcoming Challenges and Best Practices, will also include lots of lessons learned. We have 3 presentations today, the first of which is titled Capitalizing on Data Quality for Improved Analytics. This will be presented by Mike O'Neill, CEO of MedicaSoft, and Alex Vaillancourt, CIO of the Delaware Health Information Network. And with that, let's go to our first presentation.
Thanks. Alex and I are really happy to be able to team up and talk about the topic of data quality for analytics. Alex and I have the opportunity to work together on these types of problems. With Alex worked at the HIN Delaware with DHIN and at MedicaSoft, where we provide the technology platform for DHIN. We're hoping that we can leave you with a few takeaways from our talk here. First, that in the world of analytics, using a rich set of data from clinical data, claims data, data from patients, social determinants of health, that's a really, really powerful resource that drives a lot of value-added analytics. The quality of that data, both each individual data set and as you look at it together in aggregate, has a direct bearing on the quality of your analytics. There are a number of common problems and pitfalls when you deal with data quality, and that we think taking a platform approach, an end-to-end approach to working with your data is really the best way to address data quality. I think we'd like to get started, though, by having Alex talk a little bit about DHIN and their approach to analytics and some of their real-world use cases.
Thanks, Mike. So when we think about analytics, we think about wanting to be a credible source of truth for what we're reporting, and that often involves a few common pitfalls that we often run into. And so I want to cover a few of those just as a precaution as we all think about the data that we deal with. We even refer to these as data pipelines. And so what often happens is, as you see in the little diagram, we want to focus on step 1, and we want to get that just perfect. And then we want the data to go to step 2, and we want to get that perfect. And if we keep doing that, by the time we get to step 6 or 7 or 8, 9, 10, we often realize that we probably needed to have fixed a few other things in step 1 and 2 and 3. And so it becomes this challenge and a delay in trying to figure out how to do some of that. And so just one of those common areas of how can you deal with data across all of these steps simultaneous. So start to let some of that data flow, get it all the way in, even start to report something and see what would show up in your reporting tool that may help inform how you could set up each of those steps a little bit better. The other pitfall that is quite common is we all want all the data to be included. But if we've got 1,000 claims that can't get ingested for some reason, if we're talking 5 million records that we're trying to import, 1,000 is pretty piddly. And so there's got to be some level of risk or tolerance that we say, maybe it doesn't have to be 100% perfect, but we're willing to take 99.99% So as we deal with each of these phases, some loss of data is okay. It's all right. And it also depends then, of course, in knowing who your audience is. And do they really need to know, unless you're going to a patient level reporting, are they looking for more just a guidance? Are we at the 87th percentile? Or are we at the 47th percentile? And so being that perfect and precise probably isn't worth the time and energy that we would spend in it. The last pitfall that I often see with organizations, and something we are also trying to learn to continue to improve on, is a quantity of reporting. There's a desire for all of us in this analytics world to really like to slice and dice data. That's kind of why we like and we enjoy analytics. But the more we slice and dice it, then that turns into 15 reports for diabetes, for example, when the users may not want 15 reports, right? They may be looking for what are the 2 or 3 actionable reports that would make sense. What do we need to chase? What do we need to fix and address? So rather than focusing on a quantity of reporting, it's what's the value add reporting that we're trying to bring? What's the actionable information we're bringing? So I'd like to share a real world example. So something we're working through at DHIN is pharmacy data. And so we're trying to use pharmacy data, and as both the HIE for our state and the APCD for our state, we feel like we're in a pretty good position. We should be able to bring pharmacy data together. And so how do we help clinicians with medication reconciliation, but also use that data for improved and advanced analytics for things like research studies, et cetera? And so the typical process that most of us would be familiar with is that step 1, the medication's ordered for the patient. Step 2, the patient fulfills that prescription. And step 3, the patient takes the prescription. What does that mean in terms of data sources? So it means that medication ordered, for example, only comes on the clinical data record. So typically a CCD, for example. And how do we extract that out? How do we actually make sure that we know where that data is coming from? So that type of information only comes through the clinical record. From a patient, step 2, a patient fulfilling their prescription only comes via a claims record. And then of course, step 3, what we often think is utopia, is wanting personal data to, if somebody captures their own, that they're taking the medication. What does that mean from a data quality? It means for DHIN, we've got not only the clinical data pipeline, we have a claims data pipeline. And then there's even kind of a third step of how do we normalize those together? How do we dedupe? How do we do all those things to bring those 2 data pipelines together so that we're talking about the same patient, talking about the same drug, all those things. We're talking about the same data source, et cetera. So quite a few challenges that as we're working through this, we don't have an answer yet. We're still working through it ourselves. But I think the important part is that we're trying to think of it very holistically, and having a single platform is kind of what's valuable in bringing that all together into one, rather than having these siloed data approaches that would make this very complicated. So when we talk about platform, Mike, I'm going to turn it back over to you. Kind of talk about that.
Great. Thanks, Alex. Well, actually, Alex mentioned a range of things that are elements of data quality, whether it's just fundamentally making sure we can match the right data to the right patient, whether we're dealing with duplicate data, policies applied to data, and coding of the data itself. What we found is that if we take a siloed approach, and by that I mean develop a solution, a technology solution for each use case, we end up with fragmented data, and across the board, we end up actually lowering our data quality by not having a consistent approach. Taking a single platform gives us one way to have a common set of services, and importantly, a common data model, a way to represent our data, so that as we work on data quality, we can gain the benefit across the board. And one other note here that's worth mentioning: the same solution that we construct to implement use cases like Alex just described, from an analytics point of view, gives you the tools that you need to assess the quality of the underlying data. So to give some example here of the platform approach, what we are talking about here is an end-to-end technology solution that handles all the data in a set of common services and common repository. You have multiple chances to work on the quality of your data as we flow through, if you will, the platform. The initial set of data services handle things like, can I ingest data from different sources? How do I map it to my data model? That's an opportunity. That's an opportunity to transform data, to look at things like underlying code sets and deduplication and so forth, and ultimately store data in your repository in an improved form versus how you received it in a raw form. Once that data is stored in your data model, and by the way, in terms of common data model here, what we found useful is to use HL7 Fire as a standard to represent that data. That gives you a chance to address data quality in a common format that's useful for all of your downstream applications. And the other thing is we have a chance here that's not a one-shot situation. You have other opportunities to modify that data quality once you've stored it. A common example may be things like if you are tracking US CDI compliance, or the people sending you data track things like US CDI compliance, that may introduce some changes in the way they send you data or the way that it's handled. And you may want to retrospectively go back and make some modifications. And you want a data model and a platform that allows you to do that. Once your data is in a form for your analytics, then you're off and running for use cases like the one that Alex described to you. And here's where I note again, having your data in that form ready for your functional analytics also means that it's in a pretty good form for you to apply some analysis on the quality of the underlying data. How has it been modified from the source all the way through the processing in your platform pipeline? And speaking of platform pipeline, it's worth noting that data quality really is an end-to-end challenge. We're not going to talk in detail about HIMSS measures, but for those of you familiar with HIMSS measures, there's a certification process that we often focus on certifying the calculation of the measure. There's also an underlying certification of the quality of the data. Before I compute a measure, am I sure that it represents the accurate truth from the source of the data, and have I modified that in my pipeline all the way through? Taking a data platform approach really gives you the framework that you need to do certification for HIMSS measures, but that's a common theme across really all of analytics. I treat data quality as an end-to-end challenge from the source, the multiple sources of my data, all the way through my final data warehouse where I'm running my analytics queries. So to conclude here, we would say it's clear that the data quality from individual data elements to your data sets in aggregate have a big impact on the effectiveness of the analytics that you're able to run. It is something that, as Alex said, it's something that you don't want to take a waterfall approach to. You want to start and get moving on data quality as soon as you can. Make some good initial choices in terms of your architecture, avoid data silos, choose a common data model that allows you to work flexibly with your data, and then take an iterative approach. I really do think it's a journey. It's not a destination. There just isn't a final state where your data is perfect. As I think Alex mentioned, it's a process. As you go through that process step by step in an iterative fashion, it's always good to guide that by real world use cases. Sometimes I will admit, engineers like me, they like to be theoretical and build things that will be perfect. Here, there is no such thing as perfect. There's only real world data driven by real world applications. And I think Alex and I feel like that is the way that you get the most value from your data. And with that, we'll conclude. Thank you.
Thank you for that presentation. I have a few questions in reserve, but we have one from the audience. Would it make sense to layer a formal QA conformance spec on top of the APCD common data layout, much like HL7 Fire does with implementation guides and testing?
Yeah, Alex, maybe I'll comment and love to add your perspective as well as an operator of an APCD. Yes, I think that's an approach that you can take. One of the general themes that Alex and I wanted to mention is more than any one particular standard or language or implementation, is that taking that kind of platform approach gives the ability to do exactly what you're asking. Say, okay, for me using CDL, this is the way I drive most of my functional use cases. Let me incorporate data quality assessment into that or on top of that, however you think. In the case that I mentioned, HL7 Fire is a common data model throughout that end-to-end platform. So it's very convenient to put data quality tools on top of the Fire layer, but that's not the only way that you can do it.
Yeah, I'll just add to that. We do publish a data submission guide for our APCD claims data. We also publish a data submission guide for our clinical data, and yet we don't get 100% adherence to it. And so your point is valid of wanting to make sure we do some QA that says how closely to our standard are you sending your data. So if you get it coming in this way, you get it coming in this way, you kind of have a sense for, how clean is it coming in on the front door? And then you know what you're working with. And that's been a little bit of a challenge with our project related to this, is trying to go back and create kind of that data reporting report card, if you will, and say, all right, how closely are we following those standards? And
in the presentation, you talked a little bit, or there was a note about certification related to data quality. Can you say a little bit more about how much back and forth you have with your data providers or your data submitters? Do they receive quality reports with each submission, which would, be typical with claims? Just say a little bit more about your level of interaction with your data suppliers.
Alex, I wonder if you might comment directly on the APCD submitters.
Yeah, I sure can. So yeah, we work pretty closely with all of our organizations. A little less so on the clinical side. We're fairly new in the CCD space in terms of really trying to leverage that data. We've been collecting CCDs for more than a decade, but we really haven't been ripping it apart and trying to use it for each individual data element until more recently. And so that adherence and that report card is a little bit more challenging to put together. Are we following the right format of a CCD? And then is the data consistent within that? On the claims side, yes, we work pretty closely with the payers and then say, all right, here's what we got. Here's what we think we got from you. So if you sent us, you thought you sent us 300,000 claims, did we get 300,000 claims? And what's the initial breakdown of those? So, yep, it's a great question, because I think trying to provide that report card then helps your data submitters understand, I think I'm sending you everything that I've got, but is that what you're catching, and receiving, and be able to use, is it useful?
Yeah, I guess I would just add that, having worked with Alex and his team, that kind of platform approach that we were talking about gives you more than one place to impact the data quality. So it may be that a data submitter is informed by your quality analysis and your reports and knows that they should make a change, but either they cannot or can't do it in a timely fashion, or there's some lag. Being able to make adjustments in the pipeline, let's say, can let you get to the ultimate data quality at the end, even though the inputs take time to correct.
You mentioned and went into some detail about the pharmacy use case. Are there others that sort of stick out in your mind that you could describe for the audience at a high level?
Well, so part of what we're trying to do now, we've been sitting on clinical data and claims data, and we both have a very specific purpose. And we're trying to start bringing those data sets together more consistently and do some comparisons. And that's the nice thing, as Mike mentioned, about having one single platform, because we can even run queries that says, tell me all the medications you show here, in each of those data sets, and what data elements are populated, which ones aren't. So pharmacy is the one that we want to start with. We want to start, bringing in additional data sets and trying to figure out how do we link, all of our claims and clinical data together. It's only going to make sense for all of our purposes of what we're trying to accomplish going forward. So lots of use cases, I guess, is the answer to that, Jonathan.
Right on. Thank you. Can you say a little bit about how clinical data validation differs from claims? Claims database, you have submissions coming in from the payers, data stored in a central database. There's a lot that you can do with that. Clinical data is more of a hub and spoke model, right? Call and grant access. How does data quality look different in that environment?
Alex, maybe I know we both have thoughts on this. For clinical data, we like to think that there are standards that exist and how the data should get captured and coded and transferred. So first thing is to say, well, let me check against standards, whether it's to check whether an HL7 message is formatted correctly, or a CCDA document, or US CDI, and I won't go into all of these acronyms. But what we find is the standard is a great format, let's say. The content can be all over the place. And so what we found is, I guess the content is different for sure between claims data and clinical, but at a higher level, the process is similar. We do some analysis from the data as, let's say in DHIN's case, as they have it in their repository, and then trace back to see if there are things in the data quality or the completeness of data that we don't like. Where can we impact that? Could we implement in that platform some mappings? Let's say they've used some proprietary code sets and we really want national standard code sets. Can we do that? We're kind of doing that for them. If we cannot, do we need to go back to them and have them? Often it's an EHR, an electronic health record, software adjustment for how they're capturing and reporting data. There's really ultimately no way around that end-to-end loop. But sometimes there are things that we can do to adjust or improve the raw data that they're sending without requiring the multiple data sources to make changes.
Yeah, just to piggyback on that, clinical data is, in many regards, I think it's harder to deal with from a data quality perspective, because while there are standards that exist, HL7 and CCDs, formatting of that data submission is one thing. And surprisingly, EMRs are still all over the place in terms of what kind of CCDs. The big 4-letter EMR that's out there has 8 different templates that come with the system for CCDs. And so trying to determine, well, which one of those 8 do you want to receive, or which one of those 8 are they willing to send? And then the content of what's in a CCD often varies, greatly from EMR to EMR, how far they look back, all that. And so, not to mention when you start dealing with, are you talking centimeters or inches? Are you talking, all those variations as well. So yeah, clinical data can be a little bit more challenging, but it's a claims data I often describe as it's a very wide version of the record, and clinical data is the very deep, longitudinal version of the record. So both are very complementary. You need the, you need the coded version from the claims and the ICD-10s and CPT codes and all that they're, someone's using to get paid. But then the clinical record can dig under the hood a little bit and say, okay, what additional information does that give us?
Great, thank you for those responses. We need to move on to our next presentation. There is one more question related to yours, but we'll bring everyone back at the end for group Q&A. And with that, I will turn this over to, excuse me, Paul Smith, Director of Data Intake and Compliance at the Massachusetts Center for Health Information and Analysis, also known as CHIA. Please take it away.
Hello everyone, my name is Paul Smith and I'm the Director of Data Intake and Compliance at the Center for Health Information and Analysis, otherwise known as CHIA, here in Boston, Massachusetts. Thank you all for joining this presentation today. I'm excited to be part of this group on driving data quality, overcoming challenges and best practices for reporting. I'll be giving you some insight into what CHIA has done and continues to do on the topic of driving data quality in data reporting. I'd like to start by highlighting the diverse set of stakeholders that CHIA has. On this slide, I've included just some of the internal uses for CHIA reporting using the APCD, as well as our sister agencies, and of course the carriers themselves. This does not include the many researchers and other institutions that request and, if approved, receive APCD data. Each stakeholder has their own set of interests and data needs, so that presented some challenges. While accepting data on its own is no small task, if the quality isn't there, then it doesn't hold much value. So how do we successfully manage the intake and ensure compliance from over 50 submitters? What can we do to make sure the data quality has value? The answer is key account management. When CHIA began collecting APCD data from the carriers years ago, we took a targeted approach to this important data collection. Many submitters were new to the process, so there were daily calls with some that needed the most assistance. Over time, those calls decreased, but the seeds were planted with the customer service approach that we still use today. The key accounts were identified based on member and claims volume. The largest submitters make up over 95% of the data in the Mass APCD, so CHIA's focus is to make sure these companies receive the attention they deserve in sending quality, timely data. Now with this approach, each submitter is assigned a healthcare data liaison on the data intake and compliance team. The biweekly calls and monthly tag meetings allow for both CHIA and the carriers to share information, ask questions, and resolve data issues. Another key component is that for every submission, a report is created and sent to the submitter. It contains details on how the data elements did when run against CHIA's intake edits, and if the data quality is poor for a particular field, the CHIA liaison will highlight this and ask for a correction. CHIA also has a data quality assurance team, which is separate from the data intake team, that runs data quality checks once the data has been run through our intake edits and is then loaded into the data warehouse. These checks occur regularly as well as on an ad hoc basis when necessary. Data users, feedback, and questions are funneled to the liaisons to share with carriers to further enhance the data quality and thus establishing a continuous improvement approach. The data intake and compliance team is the point of contact for all of our mass APCD submitters. They work directly with the different companies' contacts, and as you can see on this slide, there are many aspects that the team is involved in, from monitoring compliance of over 50 different submitters, to reviewing reports once a file processes, and ensuring that the data submitted every month meets the deadline. Now, if a file has failed for format issues or for not meeting a required threshold, the liaison reaches out to their contact to alert them, usually within 24 hours, that a correction and resubmission is needed. So in summation, taking a targeted approach allows each of the top carriers to have an assigned liaison available to answer their questions, provide feedback, and report results to them in a timely manner. The majority of each liaison's day is spent working on their assigned carriers. The biweekly conference calls that were established have been great in strengthening these relationships. Agendas are sent out ahead of these calls and have allowed other groups at CHIA, as well as our sister agencies, to discuss their needs with the proper representatives from the carriers on the call. A lot of one-off calls have been eliminated because of these regular meetings. Liaisons are the go-to person if a question arises about a particular carrier, and they are either able to answer it or check with the carrier and report back. We've also developed a tool to track daily interactions, which we can refer to as questions arise. Compliance reports are reviewed in a timely manner. Feedback is provided to the carrier, so if a resubmission is needed, it is usually done quickly. The intent is not to have our quality assurance team find a data issue 6 months down the road. Now I'd like to share with you a success story that we've had. One example of this targeted approach having an impact on improved data quality is our work with our sister agency, the Mass Division of Insurance. Using the APCD as its source, quarterly membership reports and semi-annual claims utilization reports from the larger carriers are shared with the DOI. Carriers are required to validate and sign off that the results are a reasonable reflection of their business. Over the last couple of years, my team and the DOI have met with carriers to discuss their APCD submissions and how we could improve the data quality so that the DOI could use it for their reporting. In some cases, this led to resubmissions of prior files with improved data quality for fields that were needed for these reports. This not only benefits the DOI, but any data recipient that may be interested in those fields. Previously, these companies were required to send similar information to both state agencies, and so our goal of administrative simplification has also been achieved here. Some of the important takeaways: we've learned that the key is to have patience. This has been a gradual process. The single point of contact ensures that all communication is funneled to the correct person, and that'll eliminate potential delays. And while having hundreds of intake edits applied to the data is a good first step, it is only one piece of the puzzle. The strong relationships that have been established between the data submitters and the liaisons has led to improved data quality as well. Thank you all for your time today. I'm happy to answer any questions that you may have at this point. I'd also like to mention there are several ways you can stay in the loop with what is going on within CHIA. One way is to subscribe to one or more of our emails. All are accessible from the same sign-up link. You could also follow CHIA on social media or visit CHIA's website at chiamass.gov for the most comprehensive look at everything we do. Thanks again.
Thank you, Paul. I don't see any direct questions in the audience chat, but folks in the audience, please feel free to submit questions, not just for the individual presenters, but for the group session toward the end. Can you say a little bit, Paul, about how often the database, the APCD, is updated?
So the submissions are monthly for the most part. The claims and eligibility submissions are submitted monthly. And so CHIA runs its warehouse updating process weekly. So typically a lot of the reporting is done either month or quarterly end. We have an annual release that we do as well. But the database is updated usually weekly. So anyone within CHIA, say, that wants to run the most recent information, they can get at it pretty quickly.
I'm guessing that relatively minor data quality issues from relatively small data suppliers would not delay those annual releases or regular updates. Are there data quality problems that would delay an annual release for some period of time?
It would have to be something major. And with this approach, Jonathan, we try to catch things as the data comes in each month. So if, say, one of the larger submitters, we notice, their file failed on a field that is, critical to any analysis, we would get right back to them. One of the liaisons would reach out and look for correction. So we're constantly monitoring that with the team that we have in place in order to kind of catch those things before we get anywhere close to doing, a release or quarterly reporting even. So we're pretty on top of those situations.
Great, thank you. And 2 audience questions related to your presentation. How many carriers do you collect data from in Massachusetts? And how many people are on the data compliance and quality team?
Great questions. So currently there's about 50 submitters. And so which, some of them are smaller ones, which kind of goes to your point. We don't hold things up if one of the smaller ones has data quality issues. We'll work with them to get, better data with them. But so there's about 50 submitters, and the team that we have for the liaisons is made up of myself, a manager, and 2 liaisons. So any one of us is, in the weeds, on an almost daily basis, monitoring the data as it's submitted and reaching back out if there's any issues. So it's a small team, but it's worked out well. The feedback we've gotten from payers over the years is that they appreciate this approach because they know who they can go to if they have questions, and we have our list of contacts at the payers. So they've established these great relationships, working together for over the years.
Great. Another question, what kind of processes, checks do you have in place to assure good data quality in the data intake process? Are they manual or automated? I'm guessing a combination rather, but if you want to weigh in on that quickly.
Sure. So it's automated in that we have hundreds of intake edits. So as the files are submitted and processed, we have these automated edits in place that check each data element as the file is processing. Now we have different categories of data elements. The A level is the most important for analysis, and so those fields get the most edits and most attention. And then there's B's levels that would be more nice to have. But it's all automated, and once a file finishes processing, each file submission generates a edit error report, we call it, that is sent back to the payer. If the file passes, no further action is necessary. But if the file drops, that means there's been a format issue. So they need to correct and resubmit. If the file fails, that means one or more A-level data elements within that submission failed to meet the threshold that CHIA requires. So there's some back and forth with the liaison. They'll reach out, let them know the file failed, what it failed on for that month, and then it'll either require a correction or a threshold adjustment, depending on what the situation was.
And on a related note, another question asks, how do you split the 50+ payers across liaisons? Are the data intake team members separate from points of contact assigned to the payers, or are they the same folks?
So they're the same folks. And we try to basically have a balance of each person within the team has as equal amount as we can of submitters. No one person would have like all the large submitters in the state. It would be broken out across the team. So it's fairly equal within the team as far as who they're monitoring each time.
All right. Well, thank you. We'll bring you back in a couple of minutes. And now we need to turn to our third presentation. And for that, we have, sorry, folks, we have Laura Nolan. Laura Nolan is a senior manager with Manatt Health Strategies. She will be presenting on strategies for enhanced managed care plan submissions related to elevating encounter data quality. She'll be describing some work that Manatt has been doing with the Department of Healthcare Services, administrators of the state Medicaid program, Medi-Cal, in California. And with that, I'll turn it over to Laura.
All right. Hi, everybody. Thanks for joining our session on driving data quality. I'll be presenting on encounter data quality improvement in California. Before I get started, just wanted to really quickly introduce myself. I'm Laura Nolan. I'm a senior manager at Manatt Health, a professional services organization that works with states and payers and plans and providers and so many others in the healthcare ecosystem to improve access and quality and outcomes. And a quick note on what I'll be covering today. I'll first cover the objectives of the presentation. I'll offer a quick explanation of what encounter data is, a discussion of what's wrong with encounter data in the great and very large state of California, and what we are doing with California's Department of Healthcare Services to improve data quality and lessons learned. And I've got some contact information at the end. All right, so first, the objectives of the session. At the end of the presentation, I'm really hoping that folks will be able to understand what encounter data is and why it's important, know how California is driving improvements in encounter data quality and why, and then apply some learnings from the work that I'll present to your work on data quality improvement. All right, what is encounter data? So encounter data are the records of services provided to, in this context, we're talking about Medicaid members enrolled in capitated health plans. It's basically the administrative data that flows from providers serving Medicaid beneficiaries to capitated plans, to states, and to the federal government as a record of service utilization in Medicaid. In California, the California Department of Healthcare Services, which administers the state's Medicaid program to about 14 million people, among other initiatives, requires timely and accurate encounter data for managed care plans to maintain program integrity and comply with federal requirements. So DHCS uses encounter data to support numerous functions: calculating quality measures, capitated rate calculations, population health management. Just a couple of examples on the slide. I could go on and on. California, like all states, are also required to submit encounter data to the Centers for Medicare and Medicaid Services, CMS, via the THIMSS files. These are the Transformed Medicaid Statistical Information Systems files, and there are kind of federal rules and regulations around the quality and completeness and the format of these files in particular. So DHCS measures the quality and the completeness of their encounter data they get from plans using quality measures for encounter data, or lovingly called QMED. DHCS sends their managed care plans QMED report cards every quarter to let them know how their quality of the encounter data is doing. QMED guidance and associated report cards were initiated about a decade ago and have not materially changed since. The measures haven't been updated, and the expectations have also not been enforced. These report cards are sent to plans in PDF format, as you can see kind of a screenshot below. Not surprisingly, California still has problems with the quality and the completeness of their encounter data that they are getting from plans. And these poor quality data are passed on to CMS through those HIMSS files and can potentially put Medicaid program funding at risk. So some data quality issues include duplicate encounters, long delays between service delivery and encounter submission, so issues with timeliness, and incomplete paid amount information. So I'm showing here a map from CMS where California really stands out as having a concerningly high rate of missing payment information on encounters. And the state, really wants to improve the quality of their data for their own operational purposes, but also for their kind of reporting to CMS. So Manatt has been working really closely with DHCS to update QMED. And we have kind of 4 buckets of work that we've been working on. We're updating the quality measures, of course, wanting to reflect timely federal TMSIS reporting requirements and evolving DHCS data needs. We've been simplifying the grading methodology, whether the data are determined from plans to be of high quality or low quality. We've been streamlining the quarterly QMED report card for plans, making it easier to use and more interactive, and also introducing rules-based enforcement of data quality expectations to drive improvements. If there's no stick, then it is really hard to find improvements in data when those are really sometimes challenging for plans and providers to implement, but really important for the state and the federal government in terms of Medicaid operations and oversight. So these activities, kind of looking under the hood, include kind of many different pieces of work. So of course, we need to review and retire old data quality measures. We need to develop that simpler, more streamlined approach to plan grading. We need to transition that PDF quarterly report to an interactive dashboard. We need to develop materials for plans to bring them along and make sure they're not surprised by kind of policy and expectation shifts. And we need to make sure that DHCS is able to kind of enforce these new expectations and kind of understand who's going to do what. And of course, collecting feedback from plans is needed along the way. Just a quick example of what one of those activities looks like in practice. So as you can see on the left-hand side, this is kind of the original grading that was developed about a decade ago for QMED, many thresholds and levels and categories, and really quite a complex grading process to get to whether a plan is compliant or non-compliant with their encounter data quality. In comparison, we have a kind of a 2-step enforcement process. And now for the next generation of QMED, a plan receives a warning if there's a consistent data quality issue, and if that consistent data quality issue persists for 3 quarters or more, they will get enforcement proceedings. That includes a corrective action plan or a sanction. So just one example of what this looks like in practice in terms of simplifying and streamlining and making it a little bit easier to use for plans and the state as well. So I'm hoping that some of you can already see how this work might be applicable to data quality endeavors for you and your team. This includes streamlining and simplifying and updating data quality processes and collecting feedback along the way. Just a couple of lessons learned to highlight here for the group before I close. The first one is to really engage department or organizational leadership and key stakeholders early and often. Bring along plans, bring along associations, bring together data aggregators and data submitters so that they can kind of understand each other and communicate, especially as you're changing kind of expectations and requirements over time. Second is use every opportunity to educate leaders and team members about the importance of data quality. Data quality is not your fancy visualization. It's kind of what happens before you get to that visualization or that analysis that really makes sure it's kind of rigorous and robust. So it's really important, but folks don't always think about the importance of data quality. I'm pretty sure I'm preaching to the choir here, but just wanted to emphasize that anytime we can get an opportunity to educate folks, especially leaders, about the importance of data quality, I recommend taking it. And then third, definitely allow for additional time when planning data quality initiatives for data submitters and also data aggregators, as systems changes can take time in terms of accepting new formats or just kind of increasing the expectations around what you're getting. Lastly, I just want to be sure to acknowledge that this work was a real strong collaboration between Manatt and DHCS. I have a couple of slides here at the end, one about DHCS and all the amazing work they do, and then one about Manatt. And then I lastly have my contact information here. Please do get in touch with any questions that don't get answered today or any interest in similar work, and just really appreciate the time. Thank you.
Hi, Laura. Thank you for that wonderful presentation. Before we jump into audience questions and bring back the rest of the presenters, I wonder if you could give folks just a sense of the scale of encounter data in the state of California. It's 38, 39 million people, double digits in the millions of people on Medicaid. Could you give people a quick sense of scale?
Yes, I really appreciate you starting with that question because California is basically a small country. So the California Medicaid program, which is also called Medi-Cal, covers almost 14 million people. And so that is just individuals covered by the program. Of course, the records of services, if we're talking about encounter data, is just many, many, many times that many. So we are talking like many millions, hundreds and hundreds of millions of rows if you're thinking about a monthly or yearly data set when it comes to encounter data. So these are very, very, very big data. We have a segmented delivery system in California. So we have encounters for medical managed care plans coming in from those MCPs. And then we also have encounters from counties coming in for behavioral healthcare services, never mind specialty plans, as well as dental managed care. So it is really a very large and very complex kind of encounter data ecosystem, if you will.
Great, thank you. And we have a question from the audience. Any lessons learned regarding the process for socializing these kinds of updates with the plans themselves or the managed care organizations?
Yeah, it's a great question. I think another thing to know about California, in addition to kind of the size and the scale and the complexity of the Medicaid program, and therefore the kind of administrative data that is generated from the program, is the robust and engaged stakeholder community that we have in California when it comes to our healthcare ecosystem. And so we have a really strong network of plans, of associations, and of advocacy groups. And anybody working in the state of California on any public programs or kind of data collection associated with Medicaid will know that folks have kind of really strong opinions and want to be able to provide input when there are policy changes, program changes, and even with respect to expectations related to data quality submissions. And so we learned many lessons. We have learned many, and we continue to learn many lessons along the way in terms of kind of the best methods and modes for engaging with stakeholders. One thing that I would say is, in addition to plans, there are internal stakeholders as well within the Department of Healthcare Services that we have been working very closely with, along with our kind of data quality partners in the enterprise data quality division within DHCS. So we sort of started internal to the organization, and that was kind of a stakeholder engagement activity in and of itself. And then to get to Nate's question with respect to plans, what we ended up doing was using an existing forum that DHCS has to communicate with plans. Plans are familiar with that forum. And so we would provide information, we continue to provide information in that public forum for plans about updates to quality measures for encounter data. In addition to the plans, there are also plan associations. And so we have been kind of forging relationships with those folks and are using a different forum that they use to communicate with DHCS. And so all that to say, it's kind of a a complex stakeholder environment, and kind of the more personal relationships you can build, the kind of earlier and often you can engage with stakeholders, the better. Just some of those lessons learned.
Great, thank you for that. I think we reached the point in the program where we want to bring the other panelists back. There's a few more audience questions we'll want to go through, and then we'll wrap things up. Thank you, everyone, for your contributions thus far. I'm going to go back to a question that came in a little bit earlier. How important is FHIR for clinical and claims data analysis and assessment? Call me curious.
Or maybe I can start with that one, since I'm probably the one who brought FHIR into the discussion. So I would say first, the platform approach that Alex and I discussed, having a common data model to represent your data throughout, is an important thing. As it turns out, we think that FHIR is a good common data model to represent not just clinical data, but claims data and other types of data that you may down the road want to add, social determinants of health and so forth. It's very flexible and it's developer friendly for being able to add exactly the kind of data quality checks that we're talking about. So I guess if the question is it critical that it's FHIR? I would say, well, the critical thing is to have a good, flexible, common data model that spans your enterprise as the top requirement. FHIR just happens to be one that fits those criteria and has an extra benefit in some cases of supporting interoperability when you need to exchange data. And Alex, is that how you see it from DHIN's point of view? Oh, looks like you're muted. Or maybe it's me.
Yeah. Is that working now?
Yeah.
So part of what I was just going to add, you're seeing our federal government really starting to push the idea of FHIR exchange, especially, particularly on the clinical side. But now even what's coming at us all is the prior auths and, going down that route as well, and all FHIR based. So kind of made sense for us, and MedicaSoft's platform for us already had that built in. So.
All right, thank you. A quick follow-up from Mike. Some use cases benefit from more current data and more frequent data updates. How does that affect your approach to data quality? And Mike, I'll ask you to weigh in first, and
Sure.
Others as well.
Yeah, thanks. Well, I think what we see is with a lot of the use cases, whether it's computing quality measures or doing risk analysis or anything like this, there's a desire to have more current data than often in APCDs, we're talking about quarterly, monthly kind of data updates. In the HIE world, I would say that Alex lives in, from a clinical point of view, they generally are getting real time or close to it clinical data. Seeing like how do you move that kind of currency of data into the world we're talking about here. Maybe the briefest thing I can say is you have to build data quality into that pipeline. You can't rely on data quality always being an after the fact, like post hoc batch process. Now, obviously some things have to be done that way. If we're talking about, am I meeting certain thresholds over time, then that's true. Otherwise, you want to make as much of your data quality checking real time in your processing pipeline as you can. That way you can support real time or near real time updates to your data to meet your use case needs.
Others?
I was just going to say, based on even Paul's presentation, it depends on your data senders and how often they're sending you data. So if you're getting claims data monthly, then having a report card that goes back in a timely manner, is important, rather than, 6 months later when you finally have a published report and saying, oh, by the way, your data from 6 months ago had errors that we couldn't use. I think it makes a lot of sense. And so if it's real-time data, or if it's monthly, weekly, whatever, the timeliness is the turnaround that you really have to bake into that process.
Yeah, you don't want to have to ask them for resubmissions from a year ago.
No fun.
No, because then those things have to be communicated to your data consumers. And
Yes.
Yeah, I think we've all had experience with that. Laura, any thoughts on this particular question?
No, I do see a question in the chat that I'd be happy to answer that's kind of specific to the kind of content that I presented on. So I don't know if we're ready for that.
Sure, let's move to that one. What feedback do you usually receive from the data submitters about the report cards? What would be your next steps for the feedback?
Yeah, this is a good question, and I think gets at some of the kind of different interests and priorities between submitters and aggregators of data. The feedback on the report card historically has been very positive. I think plans don't want to rock the boat when it comes to expectations of the state when it comes to their encounter data quality. And so I think they have been very keen on providing the department kind of positive feedback on the kind of previously existing approach and the report card. But the data that is currently being submitted is not going to meet the state's needs. And so the department has, in the process of updating the quality measures for encounter data, been eliciting additional feedback from plans now that QMed is being updated. And so it's been very, very helpful to receive feedback from plans. They pointed us to new sources of information and kind of new guidelines to providers that was not immediately apparent as we were working with the plan specifically. And so that has been really, really helpful. And we've been working with the department to incorporate that feedback and the adjustments to the quality measures reporting. So that's at least my first reaction to that question.
Thank you. Paul, do you want to speak to plan reaction and feedback?
Yeah, so they do appreciate it a lot because, catching things early on is, the key for them and for us, because sometimes they don't even realize, there may be an issue where something went kablooey one month, and that we're catching it before they do sometimes, and so they do appreciate that level of insight into the data that they're sending us. Most of them do their own quality checks before they send data to us, but sometimes something may slip through and we catch it, and they're able to fix it and turn around pretty quickly. So. Yeah.
Excellent. And to Alex and Mike for some final thoughts.
I'll just add, I think, we're all in agreement that data quality is important, and it's really what's the outcome that you have in mind, trying to normalize your data. And if you're trying to figure out, might want to focus on race, ethnicity, and gender, that may be more important than trying to, normalize based on, anything else in the data. And so it's just, kind of picking and choosing your battles, because the data management piece is a huge, wide open, and you could drive yourself bonkers if you try to, think perfection is your goal. So kind of pick and choose, kind of chip away at it and keep moving through that.
Mike, last word?
Yes, for sure. I'll tag on to where Alex left off there. Treating it as the process, not an end perfect state that someday you'll achieve, I think is critical. A number of the things that I commented on here, and you probably heard in Alex's use cases, are when we start to expand analytics and expand our work a little bit beyond just the claims data that we received and worked with for years in an APCD environment, adding more and more clinical data, for example, or social determinants of health data. I think if you have not yet tackled integrating data quality into your end-to-end process, as you start to add more types of data, the cracks will show in that, and you're going to need to do that in order to have confidence that you can link multiple types of data together accurately. You have to rely on data quality. So it's something that if you have a robust process, fantastic. And if you don't, no time like the present to start working on it, because likely as we go forward, people are going to be asking all of us for more data faster for more use cases.
Indeed. Excellent. Thank you. And with that, I hope you will all join me in thanking our panelists for their presentations today. and for a great discussion. And with that, I will turn it back over to Charles, our Master of Ceremonies.
Thank you. We appreciate you, Jonathan, past NAHDO board chair and APCD whisperer, for organizing and moderating the session. Thank you to our speakers, Mike, Alex, Paul, and Laura. And thank you to everyone for attending this session. Up next are networking sessions, where you will have an opportunity to talk with Jonathan about cost driver analysis, as well as a couple of other rooms focused on different topics, including transparency data, which we talked about this morning earlier. So I hope you all enjoy. Thank you.
Thanks, everyone.
Thank you.